Thank you. So we move from the past to maybe the future. I've chosen to present this paper regarding addition of blinatumomab to chemotherapy in patients with infant lymphoblastic leukemia. It was published last year. And what do I do? Oh, no, this one. Oh, there you go. Okay, so why do I want to present this study is because I think it points to the future, and with addition of immune therapy to chemotherapy backbone, I think it's here in certain perspectives, and it's definitely coming more and more, and hopefully we can retain high event-free survivals and reduce burden of toxicity, as Martin was speaking about. So just a few words on infant leukemia. It's defined as leukemia with a debut before the age of 1. It's a rare condition, only 4% of childhood cancers. 75% of these children are KMT2A positive. Relapses occur early, and survival after relapse is very poor. I'm sure most of you have seen these survival charts before. These are for childhood ALL aged between 1 and 18. These are from the St. Jude data, and as you can see, in their latest protocol, they're up to high 90% event-free survival, which is what's generally being reported. The same has not been the case for infants. These are the two studies by the Infant collaboration, 1999 and 2006, and they had event-free survivals of around 47%. And more importantly, the KMT2A positive patients had an even poorer event-free survival. Blinatumomab is a bispecific antibody with a CD19 antibody binding to the CD19 on the tumor cell and CD3 antibody binding to the T cells, resulting in two things, T cell activation and proliferation and apoptosis of the tumor cells. And it has been widely studied in relapsed and refractory patients with ALL and shown to be safe and with some quite promising results here. So back to our study. They included patients with infant ALL that were KMT2A rearranged, CD19 positive. They had 30 patients in the study, 9 of them were high risk, and the criteria are seen there for high risk. And they added blinatumomab to the Infant backbone. And they had a criteria of less than 25% leukemic blast after induction. This is how it looks. And it's given continuously. It has a short half-life, 15 micrograms per kilo for 28 days, which is still is the general regimen. And these are some of the results. Let's see, there you go. So end of induction, of course, is the same because no one has received blinatumomab. After 2 weeks of blinatumomab, you see 90% have either MRD negative or are very low MRD levels. And with the addition of additional chemotherapy, all of them were MRD negative, so which is quite impressive. Their overall survival was high, 93%, and their disease-free survival was around 82%. And when you compare this to historical controls, this also looks quite nice. And as I said earlier, relapses occur early. I think this is probably the reason for the 2-year cutoff. And they had 1 death during remission, which was unrelated to blinatumomab. They saw 4 relapses, 2 combined CNS relapses during maintenance in the medium risk group, 1 isolated CNS relapse in the medium risk group, and a combined CNS relapse and bone marrow relapse in the high-risk group. And their toxicity profile showed that no events led to discontinuation of blina. This is just a table that was there, but it's also written in the text that they did not see any severe events with the cytokine release syndrome or neurological symptoms. And if the patients I've seen treated for infant leukemia have quite toxic regimens. And so the future is here. This is the current infant protocol, where, as you can see, blinatumomab plays quite the role here. It's added into the chemotherapy backbone. And also this study by the UK group, where they replaced blinatumomab for patients that had severe toxicity, also showed very promising MRD results. In the Altogether study, there's been conducted a study with giving blinatumomab to children with Down syndrome. The results haven't been published, but they also look very promising. And in the INTRAL, the relapse protocol for B-cell precursor ALL, immune therapy is also playing quite a role, and even inotuzumab, there's an inotuzumab randomization there as well. And it is being studied extensively for ALL, but as we heard yesterday, it's in high-risk neuroblastoma. We're looking at CD19 cells or CAR-T cells, and so immune therapy is here. But of course, there are certain things we need to discuss. It's an expensive drug. In the next Altogether protocol, they are considering to include blinatumomab in their backbone, but we need the companies to supply the drug. It's an availability issue. What about CNS therapy? Do we need to give more ITs? Do we need to give triples to everyone? There are things that we need to consider here. And also the toxicity profile, which looks very, very good compared to conventional ALL therapy. And of course, we still don't know much about long-term survival, but it looks promising. So maybe the future is looking bright. We don't know. I'll take Michael Chievoxel.
Any questions?
I can just make a comment about long-term survival. We just performed an update of the follow-up of our cohort. There's no additional relapse. So I think this 82% EFS, this means cure, and this is really, really a big, big breakthrough for this cohort of patients, because before this trial, when we were sitting in front of the parents and they asked us for prognosis of an KMT2A positive infant ALL, we had to say below 50%, and now we have reached 82%. And I think this is a great success of an international collaboration.
I wonder, in your questions, you wonder if the company is going to provide the drug. But you have like the wonder solution, right? It's very effective. So why shouldn't it be reimbursed?
I can only speak to, I was a spectator for a discussion where they were discussing if Amgen would supply the drug for a protocol, which is...
For the Infant 21 study, they are going to provide the protocol, the drug. So we will get it. We are in, Martin can also... Oh, for the Infant 21, we will get it.
Only in some countries.
How is the registration status, and how are the HTAs with this medicine?
It's not a very pleasant issue, because here we have the collision of Amgen's interest and the pharmaceutical agencies. Right now it's approved in Britain, for example, so you can get reimbursed, but not in France, not in Germany, not in Austria, not in Italy. You don't even have expanded access, so you have to pay for it. And as you said, it's a very expensive drug. And I think in this population, it should be reimbursed. But it's not yet approved. This may happen early next year.
But what do you mean by approved? So there is marketing authorization for this indication? No. So we need that first, and then we need the HTAs. But the UK has...
Yes.
Okay.
In the US as well.
For the infants, this has been granted in Italy, for this indication specifically, not for all the indications approved for adults. For example, I think that in the UK it is allowed to use, even in first CR, for MRD positivity, not for relapse, and so it's quite simple to get the drug in UK. In Europe, for infants, based on this data, this has been approved, at least in my country. But the problem is that less toxicity is not considered adequate to release the drug for reimbursement.
The reason I'm asking is I wonder if for a future study, should we have cost effectiveness analysis already in our academic studies included?
Yeah, I agree with Martin.
I also always agree with Martin.
But I think another important aspect is that right now we have a very, very efficient therapy for ALL. We have event-free survival of above 90%. No, I'm not talking about infant. Now I'm talking about putting it into first-line therapy for childhood ALL. And one of the arguments you may have is that you have some very efficient therapy. Why should we pay so much more for something?
Well, but I think the point that Carmelo is making, toxicity is another argument.
Yes.
But the HTAs expect another way of toxicity documentation, with sometimes they're used to adults filling out quality of life questionnaires, and then they ask you what the quality of life improvement is in this infant. So we have to change our way of thinking and start this earlier so we can more easily get our medicines approved for reimbursement.
Yes.
Right now the situation is, let's say, difficult, but it's also not a harmless drug. It is a drug which causes the highest amount of seizures that I know in pediatrics, pediatric oncology. And therefore it's not completely harmless, and I think one should have clear guidelines how to use this drug. We tried to get early approval for this agent because we did a randomized studies and we published, at least at the ASH meeting, the toxicity data, which were absolutely clear. But the EMA says, well, without outcome data, we will not give approval. That means for now, it's approved in UK and US, at least for adults, but they also do the payback for children, but not in general. So I think we need to wait for 1 more year. In infants, it's different, but the outcome is different in infants anyway than in the general ALL population.
Thank you, Ryan.
Thank you.